Thank you very much to all of you out there. I can't see you, but I know you're joined, and we have a significant number of people signed up for today. Today is webinar number 6. I suppose, again, just to go back over the purpose of these webinars, the purpose of these webinars is to share experience that people have across the system, both in the acute sector and primary care sector and the community, around good practice and what we can learn from each other. So the spirit of the Patient Flow Academy is collaboration. Just to walk you through today's webinar, we obviously have the title of the webinar is obviously Understanding and Addressing the Urgent and Emergency Care Challenge. And we're going specifically focusing on the Mater Hospital. And we're delighted that the talk today and the learning today is going to be delivered by the Mater team. And that team includes Heather Coetzee, who's the Interim Chief Operating Officer in the Mater, Aileen, Igoe, who's the Lean and Systems Redesign Lead at the Mater Transformation Office in the Mater, and Siobhan Manning, who's the Service Innovation and Design Lead at the Mater Hospital. We will then, maybe after the 35 or 40-minute presentation, which I've heard before and really is fascinating, absolutely fascinating, so we're delighted to have the Mater team on board. We will be joined on the panel then by Professor Jim Egan, who's the Clinical Director at the Mater Hospital, Professor Peter Kearney, who is the Regional Clinical Director for HSE South and West, and Kieran McDonald, who's the General Manager for Naas General Hospital. I would remind people there is a Q&A function which we like to use, and so please put questions into the Q&A session to encourage a conversation that goes forward and backwards during the panel. The session is recorded. All of our previous webinars obviously are available on the website, which is the Patient Flow Academy website, easy to find on the HSE, and I think is building out a bank of really good learning opportunities for the system out there. We might just take the next slide. Just before we call in the Mater team, really, I just want to thank people for attending the Patient Flow Academy National Conference, which we had in Dublin in the Gibson Hotel on the 13th of November. And I would point out to you, obviously, the recordings now this week have gone up on that website, which is below www.investnet.ie/patient flow event. So you can find the recordings in 3 separate sessions on that website. So I think it's useful to look back and to listen to the learning on that day. So I'd like now to invite the team from the Mater to come on screen, and we're going to hear the piece around understanding and addressing the urgent and emergency care challenge of the Mater journey. So thank you very much, Heather. Thank you, Aileen, and thank you, Siobhan.
Thanks, Mike, for the introduction. So thank you, everybody who's joined. I know that this week is not the easiest week, and appreciate that everybody's taken time out of their days to join, and hopefully you get something meaningful from our discussion today. I think if we look at the title of this and it says the Mater journey, I think in many ways journey is it seems a very soft term for what we've been doing. In many ways, this is an epic or a great track. It's a journey that we've been on for a long time. This is certainly not our first attempt at trying to address what is without a doubt our biggest challenge at the moment, which is unscheduled and emergency pathways in, through and out of the hospital. And I think this week, for anybody who's working in either community or hospital, will be a very clear example of the types of challenges that the system is experiencing at the moment. So we've looked at this before. We've done lean projects, we've done rapid improvement events, we have local engagements with clinical and operational staff to try and introduce new measures. And in many ways, we know the solution to some of our patient flow and unscheduled care difficulties. And the question, of course, is why don't they stick? If we know what we need to do, why are we not having more success than we've had so far? And what we'll discuss today is a closer examination that we're taking as a hospital, looking at the environment, the context that people find themselves in, the way that people are interacting within that context, and the type of impact that that can have on people's behavior, and also a very, very deep dive into certain areas of the challenges that we see. So we will share our journey so far. We're only on the way. There is a lot more to come, but there may be something that would be useful within your context. So I'm going to hand you over to Aileen or Siobhan.
Thanks a million, Heather. So yeah, as Heather said, we've been sort of going at this for many years, and people all across the hospital have been involved. Lots of really strong initiatives already in place, like, you know, the FIT team, collaborations with community, Smithfield Rapid Injury Clinic, and so on. And yet it still feels like we're sort of running to stand still with the problem. So with this, when the executive and the board of the hospital asked Transformation to work on this, we decided at that stage that we wanted to go, I suppose, even deeper than we had before, and to take a slightly different approach to see if we could shed new light. So in Transformation, we use a mixture of lean methodology would have been very strong in the early years. Transformation is, for those who aren't familiar, Matter Transformation is a unit within the hospital that works with frontline teams to solve all kinds of problems. They can be small ones that bubble up from the front line to major system ones like this. And over the years, we've come to a point where we use a mix now of Lean Six Sigma methodology, design methodology, and then everything that we do very much has collective leadership and teams to the fore. So we decided to, I suppose, hopefully what you'll hear through what we talk about now is how we decided to apply all of these, as Heather said, in a kind of really, I suppose, slower, considered way to see could we shed new light on things. So the methodology then that we used, so we started and we continued throughout the process to just really chat to people one-on-one. So over 100 staff interviews at this stage, right across clinical, administrative, operational, everybody, to just sort of get that real sense from people of where they're at and what they're seeing and experiencing. We did about 20 what we'd call GEMBAs, which is basically structured observations. So sort of a lot of those were ward rounds with the teams, then observing up on the wards, getting the nursing and HSCP perspectives, in with patient flow, down in the emergency department to really get into observe, and then whatever we observed, go and follow up on it by looking more deeply at data. We also did a point prevalence study. We did a number of them and began on the 20th of February last year, where we'll talk through that in more detail. We took a snapshot of who's in the hospital and why and what's holding anybody who could be elsewhere. And then extensive desktop data analysis to sort of validate the insights that were coming out of all of these other aspects of the methodology. So just to start off, one of the things I suppose that has emerged is that there is what we seeing and feeling is really two key areas. One of the system and one being bed days, and how we may lose bed days in the system, where people maybe sort of could be gone from the hospital but then are delayed for some sort of a reason. So how we might salvage bed days to enable flow. And then on the other side, or another component of the system, is the sort of the time of day of discharge. And that we felt that it was important to kind of separate those two out, because while some of the same factors influence both, there's many, really they are quite different in ways, and there's different things that we need to target if we're going to address them. So I'm going to start off with the bed day side, and then Aileen's going to talk more about the time of day piece. So in terms of the broader context, so this is looking kind of at really macro, what's changed over the last 10 years and so on. So obviously we all know this, the population is increasing and it's aging. Which is obviously affecting us. In terms of the CSO data then for the Mater kind of catchment area, we know, and it's no surprise, it was no surprise to us that our population is in, I suppose, a more disadvantaged population. And of course, CSO data only shows you the data from those that fill out the CSO form. So if anything, the more marginalized groups may not even be included in that data. We also know that our attendances to the department, like in many places around the country, were going up. But our percentage of admitted patients is staying relatively the same. So essentially, the hospital is having to deal with a huge, continuously increasing number of attendances and admissions to the hospital. One of the things that we were seeing and hearing from people on the ward was around, I suppose, what we call the social inclusion issues. And certainly, I'm originally a speech therapist and would have worked in the emergency department and on the wards many years ago. And when we were on the ward rounds, you could sort of feel this sense of complexity of cases that were in front of, that were in the beds in the hospital. And we delved into that more, talking to people in social inclusion and talking to the individual teams. And the numbers in terms of homelessness really jumped out. So there was just every ward round we went on, they seemed to be talking to people who were living in homelessness. The data that you have in front of you here is the data that's captured nationally through hype about homelessness. And the figure there that you see for the Mater for 2022 was 130, whereas through a more in-depth analysis, we knew that the real figure that year was probably tenfold of that. So there's two things there. It's the large number of people that are living in homelessness and presenting into the system, but also the fact that we're not capturing it and seeing it on a national level. We also did, Heather will speak to it more in a little while, but we've done a very deep dive into 1 week of emergency department presentations. And again, we saw it there. There was it was actually 13% of people that were living in homelessness, but 11% when we were strict in sort of removing those that may have been coming in more accommodation seeking. Talking to social work then, we dived into that a little bit because they were talking to us about the complexity and the pressure on social work because of all these socially complex issues arising. So they had experienced a 52% increase in the number of referrals to social work from the emergency department over 2 years, from 2022 to 2024. And they also tracked the complexity of the referrals that they get. In 2022, it had been 50% were deemed highly complex. And in 2024, in April, 81% were deemed highly complex. The other figure I just mentioned there, that 11% of patients that are presented to the Mater ED, this was from a week in June, where we sampled 1,257, 11% were living in homelessness and seeking clinical care. So this is a very striking thing that really, so I suppose the process and going slowly and talking to people and really taking our time with that data has helped to really bring to the fore. And what's particularly, I think, important here is that, you know, we talk about complexity in healthcare, but we're often talking about different things. So in terms of ABF complexity, somebody who's had a very complex surgery with an ICU stay will be sort of considered to be very, very complex. And sort of medically, we think of them as very complex as well. But social complexity brings up a whole other thing. So, and this is something that we very much saw on the ward rounds, and we're hearing from people that if you've got a homeless person who now has, who's had COPD, probably poorly managed because of difficulties engaging with the system, and they now have new long-term O2 requirements, that patient is almost just undischargeable. You have to be incredibly creative to try and discharge that patient. So it's adding this incredible complexity to the flow of patients through the system. One of the initiatives that's underway here was actually, so the social inclusion team at the Mater had already been working on this and sort of seeing the importance of it for the unscheduled care programme. We've come in on it, Transformation has come in on it as well to try and support it. So this initiative is about, I suppose it's recognising that people that are living in homelessness or other social inclusion areas like living with addictions and so on really, really struggle to engage with the healthcare system. And so they tend to turn up in the healthcare system in crisis in ED. And this initiative that the Social Inclusion Hub, which will be set up in Summerhill, the idea is to try and create an environment where people can access that kind of urgent care and engage with specialist clinical needs without it sort of presenting then in the ED, or equally it might enable a sooner discharge of patients from ED or from the hospital where they could be the care could be picked up in this hub. And so what we're doing here is one of the things that the social inclusion team highlighted to us is that you can create services, but people who are marginalised in this way often struggle to engage for a variety of reasons with services: chaotic lifestyle, difficulty attending appointments, fear of institutions, and sort of a fear of sort of being judged when they enter hospitals, many, many other factors. So we're doing a design piece funded by Spark Innovation Programme, where designers are actually interviewing staff, but also really importantly, patients that are in the hospital at the moment that have gone through services to really understand why they ended up presenting to ED or why there's a struggle to get them home. So this has become a very core part of this project. Another area that really jumped out was around oncology. So the bed base for hematology oncology in the hospital was 31. So one thing that people were telling us, management, staff, everybody was saying that the oncology is spread all over the hospital. So their base ward is full. And then that there's oncology patients throughout the hospital. And so the census year to date for hematology oncology, I'm going to say year to date, that would have been sometime Q2 last year was 58. So they're almost double of what the bed base was. And so we looked into it really deeply to try and understand what is going on there. Is there inefficiencies in the system that we could maybe go after, particularly with that kind of Lean Six Sigma lens? What we actually found was we attended MDTs that the patients that were in the hospital were incredibly sick. 74% were stage 4 disease. And there was a constant push to try and discharge in the best interest of the patients to get, if they could get them home, they were going to get them home. So we were surprised, I suppose, and then I suppose part of us a little disappointed that there wasn't maybe as much fat in the system that we could go after with that one. And then we looked, of course, at the international trends. This is very much in keeping with what would be projected, the numbers of people that are living with cancers now, because there's more treatments, they're more successful, but people are living with advanced cancers for much longer. And of course, they're having to utilize the acute hospital systems because of that. So really the message here, the learning here was this isn't going anywhere and we're going to have to deal with it. And there's a serious capacity issue. So the point prevalence study that we did, I'm just going to show you one of them. The major one was for the kind of the medical specialties that feed into the general the give take process. We focused on them, and then we focused on surgery and other areas to see if the patterns were the same, and they were largely. So we're going to talk you through the one from the medical specialties from that data. So essentially what we did is we took a snapshot of all of those patients. So it was 406 in total, and we met with consultant or senior reg who was on service at the time on the day. I think it was around 12 noon, and we asked them, talk us through why all these patients are in the hospital. And we wanted to capture firstly those that are medically active, then the second category, those that they could in theory leave the hospital if certain criteria were met. So if they'd had their MRI done to outrule something, if they had a rehab place, etc. And we documented and analysed what those factors were. And then we looked at those that the team was saying they could actually go today, they're just waiting for something, or the plan is for them to go today. But in their mind, the plan was that they would be gone that day. So as I said, there was 406 patients in that on that day in this data set. So almost a quarter of them were in that B category. So this is a massive bed day savings issue. So about a quarter of the patients were waiting for something in the hospital. And just to give you a flavour of what they were waiting for, so the most common there was the home care packages adaptations, then a number waiting for long-term care, radiology, rehab. There were some that would be double listed there, so the number doesn't add up fully. So some patients would be listed for waiting for long-term care, and that process will have started. But equally, we were trying to discharge them to our step-down facility in Fairview, which makes sense. So they're listed in both. In terms of looking at this to see, okay, what could we go after here? Where would we get kind of really good bang for our buck to try and salvage sort of bed days and release some of those patients who really will be best placed not in the acute hospital? So this, of course, is this chart here is showing you the number of instance. It's not showing you the number of bed days. So the home care packages and adaptations, it looks interesting there. Actually, when we looked into it, most of those are very short. There's just a large volume of very short bed days. And there was some where there was longer delays waiting for home care packages or adaptations, for example. They tended to be out of the catchment area, or just we knew they were going to be more difficult, not really within our control. So it's not an area we're going to go after. Whereas areas like radiology and rehab, the number is only 17, but the bed days associated with that was significant. Within radiology, I think it was, how many of them were MRI? 7, was it? 7 were MRI, for example. We know that problem is only going to get worse this year because of NTPF funding being pulled there. So, and we also know, having worked with the radiology department many times over the years, that they've done significant work to really sort of lean out the services there, and we're really optimizing. There's not a lot of give room there. We're going to look a little into kind of how we prioritize, and is there more we could do to make sure we prioritize the right patients for discharge, but there's not a huge amount. In terms of rehab, we've circled that one there. The interesting thing is that we found with medicine, with surgery, about a third of those are essentially have no suitable destinations available. So they're not just waiting to be transferred or waiting for a place in the NIH. There's literally nowhere that will take them. A lot of that would be because they're under 65, massive issue, which everybody on the call, I'm sure, is experiencing. But also a lot then who just were very complex socially, maybe had addiction issues, behavioural issues. So a lot of places just weren't accepting them. So essentially undischargeable. So Aileen now is going to move on and talk about that the other piece of the system, the sort of the time of day bit that we looked at.
Thanks, Siobhan. So as Siobhan said, and as you can see, there's kind of two scales of investigation that we carried out, and that we started to understand and separate a little bit, even though they're really interconnected. So as Siobhan's been talking about, the kind of bigger scale bed day savings, and often this is where the conversation went to first. So for instance, when we engaged with the Division of Medicine, they were really keen for us to look at that point prevalence to understand those big drivers of bed days through the system. And it was interesting that sometimes these kind of themes were used interchangeably. So bed days and time of day, sometimes there was kind of message fatigue around it. And we found it just really important to pull each of them out and look at the variables independently, because there's different factors affecting. So if we start drilling into time of day, we started to look at the time of discharge, typical time of discharge across all specialties. And this is overall medical specialties that contribute to the general internal medical rota. And so you can see that in or around 3:45 in the day is our median time of discharge from the wards. So we know that this isn't ideal, and this is one of the major goals of the project, is how do we start to shift this left, and how do we start to enable discharge earlier on in the day. When we started to look at it, we knew that there, because as both Heather and Siobhan talked about, there's been so much work done on this previously. There was that question of how do you start to engage people in the conversation? How do you start to get past that we've done this before? That kind of fatigue about what, yes, we know the emergency department is busy, but everybody is really busy in the hospital here. And how do we start to really highlight the risk that was happening in the emergency department? So we decided to look at developing a way of understanding that first through data, and then trying to represent that and communicate that concept. So we worked with one of the designers in matter transformation, Alan Coleman, to develop this kind of abstract diagram of an emergency department. And this shows how in utopia, an emergency department works. And in an ideal world, some people are coming in, they're being registered triage, moving through the system through ED, either admitted or discharged home, and that there's this nice flow throughout the day. The reality is more like this. So this was based on real data on the 28th of February, and I'm sure it's familiar to all of you on the call, but at 8 a.m. in the morning, you already have an ED that's full. And the blue rectangles, they represent patients that are already admitted and that they're waiting to be pulled to the ward. And you can see at 8 a.m. there's congestion already, and then at 11, which is the peak time for people to go to their GP and come into the ED, you just start to see that congestion building. And we know the patient experience time, how critical that is and how risky that is. And that's very well documented and very well known. But what we were finding the impact wasn't fully talked about is that whole system impact. So if you're working in an ED, how this makes it really difficult for it to actually function, for an ED member of staff to actually even find a cubicle or space that a patient can be assessed. Constant kind of moving around and deprioritizing of patients to see as people are sick or coming through the door, who can we move out? How can we kind of start get some flow going in the system? You can see then that queues starting to build up at triage and at that kind of awaiting assessment piece. So those really kind of critical points, and really where a lot of the risk is being carried, that we're seeing times of triage going to 1-2 hours when you see this level of congestion. And interestingly, and really the point we were trying to drill home is how this actually impacts the whole hospital as everything cranks to a stop, or comes to, this kind of full point of non-movement. And you see that there's delays then, for kind of the handover to the admitting team. You see delays, you see pathways closing down, as one of the ED consultants said to us, daytime ED medicine is very different to nighttime ED medicine. So pathways that are available during the day not being available. So all of this just really kind of coming to a point and having this big system impact because of the congestion. And we can see then that the pull to the ward really only happens after that discharge time, or median discharge time being that kind of 3:45. So from that time onwards, that's when you're starting to get the pull to the ward. So we created this animation. We're starting to disseminate it with teams, and we're starting to have that discussion, and we're starting to see a kind of a connection of the dots, I suppose, and people identifying their role in the system and actually how a discharge in the ward, the impact that that might have in creating this more consistent flow through the system. So we wanted to start opening up the bonnet on a lot of that, and really understanding that the kind of time of discharge and why was that so late in the day. So we started looking, Siobhan mentioned earlier about Gembas, and we did a lot of Gembas at this point of time in the project. So, which was really about, it was our stalking phase. So everybody was very accommodating, kind of letting us come along and kind of see their world and see their pain points and understand their perspectives. But we went on ward rounds of medical teams. We were on wards with nurses stations over the course of the day. We were in patient flow. We were with HCPs. We were down in the ED. So kind of really walking the whole process and the whole system, and really listening, trying to understand what's behind what's going on, and try to see the patterns, because we could see that this is happening every day. So being there, can we see the trends and the patterns and understand the why behind that? So the first piece that I'll talk you through is a map that's based on looking at the kind of big organizational structures across the day and how information is passed at a kind of operations level. So this is a really impressive kind of structure that happens. So in the morning, you've got the site nurse manager handover early in the morning. And then from that point onwards, there's a kind of enlisting of the CNM3s as they go around their different wards throughout the hospital, and they liaise with the ward managers on each of those wards, and they discuss who might be the potential and the confirmed discharges for the day. They bring that information back down to a nursing huddle, and that's all that information is consolidated into a kind of one understanding of where is the potential, where are the confirmed, how can we start to kind of enable those potential patients that are going to be discharged that day. And that information is then brought into a hub, which is in the patient flow department, where you've got whiteboards on the walls, so very visual management. Radiology are there to look to see who they can prioritize. If you're rehab coordinators, they're talking about what are the particular status and context in the rehab sites. And there's, various other people that help with pathways out of the hospital. So a really kind of good mechanisms and pulling from a lot of information around the house. And then there's updates at 12, at 2, and at 4 over the course of the day. So we looked at, over a course of a week, we looked at data that patient flow department would have collected with us, and we could see that over the course of the week, there was a capture of, we were looking at the predictability and the accuracy of those potential discharges. And we could see that in blue is the number of actual discharges per day. So you can see that by the end of the day on Monday, there's ranging between 52 to 83 discharges across the day. But at that time in the morning, the predictability of those who are identified as potential leavers and confirmed people to discharge that day, that percentage was very low at that time in the morning. The accuracy improved over the course of the week. So that really led us to question, well, what's going on here? What's creating that kind of disjoint between the morning information and the kind of channels? How are those channels being blocked throughout the hospital over the course of people's day? So we started to look at the ward rounds. So as I said, the Division of Medicine were really they were a really good partner with us on this. Then they were really keen for us to come along and to see the frustrations that they were experiencing and just to see the world through their eyes, I suppose. And we did carried out these gambas with 8 different specialties on over 10 occasions, really kind of, and over the course of 6 weeks. And that was from about February, end of January till I think it was the end of March kind of time. And what we could see there, you can see the different specialties that we rounded with. And we could see that the start and finish times, you can see how they varied. So it's usually the team started in around the 8:30, and you can see the duration of the ward round varies. A lot of them finishing around the 11 a.m. time, and you can see the medians there, the duration 2 hours 15 be the median finish time being around 11. But you can see that some of them ran on much longer. So you can see number 5 there running from 9 till 1 o'clock, and number 8 there running from 8:46 to 1. In some of those occasions, there might have been family meetings mid-round. But the point being that the information at the end of the round wasn't available until 1 in the day in that instance. And this is obviously associated with the number of patients on the ward round, but also the number of wards that a team would visit during the course of a round. And also interesting and something to kind of point out, and this was really interesting in in that we got to see lots of different teams, so we could see that this isn't apples and apples, that it's very much specialty dependent, or there's definitely factors that affect each specialty. So good comparisons we could see in cardiology, for instance, they have two cardiology wards, both adjacent. Pretty much all of their patients cohorted on those 2 wards, and we could see that there was a more predictable patient journey also. So, and you could, this team, they kind of were really well organized, really coordinated, and they could run through, and they had nursing staff who attended the ward round, but you could see a really kind of cohesive team that was enabled by those conditions. And the ward round took 1 hour 25 minutes, starting at 8:30, I think, for cardiology, whereas endocrinology was a good kind of counterpointers. There was something different happening there, in that there were 17 patients, so similar numbers of patients. They traversed 10 wards across a increasingly big and kind of dispersed hospital campus, and you could see and their patient profile, they would have a lot of the general medical patients, older patients, so a lot of complexity, a lot of social complexity. You could see not only the kind of having to walk around the hospital and that in its own right, but actually the kind of stop-starting and the kind of having to reintroduce themselves reacquaint themselves with the layout of a new ward, with the notes, with the nursing staff on the ward. All of those difficulties were very obvious when we started to do the Gamba. And as I say, a very, very obvious difference was this kind of complex social discharges that was really evident for the endocrinology team. So just looking at that idea of safari rounds and numbers of wards visited, what we could see was that it ranged hugely. I've just shown the medical specialties on a particular day, which was the day of the point prevalence, and you can see that they vary. And so a lot of the time in Navy is the wards that they would have, that would be considered their base wards, and it includes ICU and any kind of critical care areas. And then in orange is the wards over and above that they had patients on that day. So you can see a very big range. And I'll talk about that later in terms of what that means and what the impact of that is. So bringing it back to, if you remember the map I showed earlier, when we were looking at the timings of those big information mechanisms across the day, if you map the duration of ward round on top of that, you can see that if ward rounds are still happening until 11 and the main kind of information dissemination has gone down between 8 and 9, that there is the kind of an async for that main hub information piece. And it's not to say that, as I said, there's kind of updates later on in the day, but there's something about the duration of the rounds and when that information is available. This is not the only factor here, and I'll go on to talk a little bit more about what other things we saw affecting. When we looked at going back to cohorting, and it's an interesting one, and it's such a difficult one. It's probably one of the most challenging aspects of patient flow, and we know, and I'm sure it's the same in a lot of your hospitals, that hospitals running at over 100% capacity. So it's incredibly difficult to, and you've got competing demands around male-female beds, isolation and infection control, telemetry beds, if there's kind of outbreaks of norovirus, etc. The list goes on in terms of that kind of competing for how do you move the right patient to the right bed. But you can see that in times of escalation that some, like in general, you can see there's a lot of wards there that have a high percentage of cohorting. It's when you, even if you look at, I'm just trying to look at a good example here, we can see Our Ladies, which is kind of a quick turnaround ward. So you can see on that day that they had 9 specialties rounding on that ward. So it's that kind of ability to have team function that becomes really difficult. The ability to communicate effectively, to build relationships with the ward staff and the HSCP staff, that just becomes increasingly difficult when the patient listing is kind of spread throughout a large number of wards and throughout the hospital. And we could see that in the rounding. So we could see that generally on base wards, there was good interaction and communication with the CNM and the nursing staff. Typically they might go on the ward round with the team, or they might have a huddle at the start of the round. But on the wards where it wasn't their base ward, that was much more challenging to kind of identify the nurse looking after the patient, much more challenging to the wards as we kind of move into single rooms as well. The wards are getting bigger, the environments are getting larger, the occasions for informal communications, that is reduced as well, and that's really interesting for us to think about. But what we saw that for a lot of nursing and definitely with the HSCP interactions, a lot of it was by chance and by happenstance, and that it might be a kind of chance meeting in the corridor as the team is walking past the HSCP, and then there's kind of an informal update as to how the patient is or what the status is. So we can see that it's not intentional. The communication it's more haphazard than that, I suppose, and a lot of that's dictated by this big enabler of cohorting. So if we think back to there's that async of information, but there's also is the information, has a decision or a potential decision been shared and been disseminated to everyone that needs to be kept in the loop so that it can be enacted, so that you can do all of these things concurrently. And we could see that when we also did a deep dive the day after the point prevalence, we did a deep dive into the discharge documentation, because we know that we could see, and we've got data on this in terms of how the discharge decision is communicated. It's around 50% of the time that it's in the chart, and that's the way that the primary method of communication of discharge. And we can see that the variability here in terms of when that's mentioned. So often it's the day of discharge before that's mentioned in the chart. And if we think back to everything that Siobhan has talked to us about, we can see how with that social complexity, one of the consultants said to us, there's lots more ducks that have to get into a row. So there's much more coordination that has to happen. And that's difficult through a medical chart, and it's difficult, as you see, the variability, if that's the only method. What we also, on a point of note, this was really evident, was this, the day is gone that a patient is waiting at the morning of discharge, waiting for their keys or the relative to pick them up, and that's the only kind of single thing. And what we saw was that there's a lot more dependencies, that if people are there on the day of discharge, there's often an intervention that has to take place. There's often lots of dependencies that kind of emerge over the course of the day. There's lots of what ifs. So the consultant might end a ward round and kind of say that there's 5 potential discharges here, but actually by the end of the day, only one of those might go. So there's something around the uncertain. It's difficult to predict. There's lots of variables in the mix. There's lots of dependencies. And also it's emergent. So the days where kind of single point of the team coming together to look at who's potentially for discharge, we have to question that and see, is there ways that we can design more dynamic, effective, but kind of user-friendly ways that teams can discuss and progress discharges across the day. So coming to the end of our point, so what we could see here is a lot this kind of vicious circle that's happening, and I'm sure that's not a surprise to most of you on the call, but this kind of disjointed communication that's really disabled by if you don't have patients cohort in the ward, that leads to kind of more difficult team communications, which contributes to late discharges, which leads to ED congestion, which creates a kind of major pressure and a pressure to place patients in the soonest available bed as opposed to a bed that might be cohorted, and so that impedes the cohorting piece. So none of this is an easy fix, as we all know, but the kind of things that we're looking at, the interventions we're looking at, is how do we start to look at those MDT communications with different teams, understanding the particular contextual variables for that team. And we've started doing some nice work with the infectious diseases team. There's a couple of teams we identified in the first instance that have been really receptive. We're starting to look at what their days look like. How can we start to co-design with them ways that work for them and work for their day, but ways of coming together across the day to share the kind of emerging information and to disseminate that and to direct the channel down to patient flow. So kind of really reinforcing those channels. Our second piece is that we're looking at how the whole cohorting piece. So how might we support patient flow in improving that cohorting? We were successful in obtaining funding from HSC Spark to look at a project that we call DigiFlow. And what we're going to look at here, we're just waiting for funding to be released on this, but what we're looking for is we're going to do a deep dive into patient flow to see how is there opportunity to look at slightly different ways of working. Is there ways to leverage existing technology that we have and maybe rethink it a little bit to see how can we support that right placement, right time? And is there ways we can support improved information to improve that accuracy? And then another piece that we're looking at is that kind of async at systems level. And I know that Heather and the team and Jim, they've started to look at additional information points across the day that might be at the end of ward rounds. But as I say, that's one piece of the puzzle. The information coming down to that has to be coherent, and it has to be across that MDT level, and has to be those kind of concurrent streams of planning and discussing and progressing the patient journey. And then we're using those kind of like that animation in all of our discussions to kind of make the case for change, to show everyone's role within the system, and to show that it actually does impact them. If you're on the GIM rota, that it actually has an impact because it impacts cohorting. All of this impacts cohorting, which has an effect on your where your patients are around the hospital. So all of those concepts about showing people what they can do and how that will impact them in the system. I'm just going to hand over to Heather just to talk about a concurrent piece of work that we're doing in terms of looking at ED, alternative pathways to ED.
So I'll keep this brief. I'm conscious of everybody's time. So I suppose one of the things that we've learned across time is that Sometimes we need really, really in-depth data to debunk some preconceptions we have. So we took a week in ED, we took all the presentations, and we have had several clinicians working with us on looking at those patients and if there were alternate pathways that they should have been able to avail of, and did those exist, or were they something that we had to seek to set up? And I'm happy to discuss this in more depth with anybody if they want to contact afterwards. But I suppose a very good example here is the notion that a lot of people are in the ED department should be at GPs. We actually set up a GP access for our department, and in fact, it hasn't solved in any significant way some of the presentations to the hospital. So there more in-depth information is required to really get to the bottom of some of our preconceptions about pathways and streaming that we think would benefit. That's not to say that we don't require more GP access, but it may not be the panacea that we feel that it may be. So from that, we hope to motivate for additional pathways. We've certainly tried to set up more scheduled pathways into the acute floor through our acute medicine unit, through various other, through FIT, through various other, and acute surgical assessment unit will come on stream in this way as well to provide more scheduled access into the department. So essentially, just to sum up, we hope that we've given you a glimpse of what we're doing in terms of trying to bring the context to life for the people working within the system, how to engage with people where they're at, to change the narrative from I need more discharges, I'm guilty of saying that a lot, to give me 2 hours. And the small differences that behavior change can impact, hopefully, on this broader system. I'll stop there.
Thank you very much, Heather. Thank you, Aileen, and thank you, Siobhan. Pretty much the second time that I've heard that presentation, but I'm absolutely struck by it, actually. And I'll invite the panel to come on, actually. So Jim Egan, who's Clinical Director in the Mater, Peter Kearney, who is the Regional Clinical Director for HSE South and West, and Kieran McDonald, who's General Manager in Naas. I think one of the things that jumped out at me from that presentation is the feeling of I'm not alone in this journey. It's not just the Cork University Hospital that is probably all of the same shared experience, really. So I might invite people to put questions into the Q&A, and I might just ask Jim first and foremost. Jim, obviously, as in my previous role as clinical director, I found it challenging to focus the mind of the medics on patient flow, equating to patient safety, and that gave me 2 hours piece. How have you sort of dealt with that approach in the Mater to mirror the fantastic work that's been done by the team that we've heard?
Yeah, so we've heard a lot about processes, and it's worth reaffirming that the demand is continuing to escalate. For example, last year we had 16,000 admissions, and this year we're projected by the 12 months to come in at 20,000 admissions. So the demand is escalating all the time. We're all aware that capacity is short, and very, very definitely capacity is important in terms of the cohorting piece. And you know that message of the inefficiency of the safari rounds is crucial. Now, ideologically here, our community, we do not cancel surgeries. We have taken a very strong position on that. We do not cancel surgery to alleviate pressures in A&E. And also, we do not move people up onto the wards. And hence, there is a whole hospital engagement so that nobody is disenfranchised to maintain the flow. And, you know, there are one, as the clinical director, you know, it's not unreasonable to say I'm blessed. There are so many up and coming clinical leaders within the constituency. People like Professor Muldoon, Evan Muldoon, Chair of the Division of Medicine, Catherine McGorry, and Colin Byrne, who's brought in the FIT services. So the emerging leaders in the community need to be acknowledged for affecting change. And one of the most important initiatives over the last year has been the initiation of a Saturday handover for medical consultants. So The medical consultants come in on Saturdays. They hand over according to speciality, and we've observed a 0.5 days drop in average length of stay associated with that initiative.
Yeah.
So ultimately, you know, everybody's working extremely hard, and hopefully increased capacity will bring more efficiencies to the system.
Thank you very much, Jim. I wonder, could I just turn to, I mean, Model 4s and Model 3s are different beasts, obviously similar patients coming into both at times, but obviously there's a lot of high-end specialist work in Model 4s. I see Kieran there, who's general manager in Naas. How do the Model 3 challenges, what's the difference, do you think, Kieran, between the Model 3 challenges on urgent emergency care versus Model 4s?
Yeah, thanks, Mike, and thanks to the team in the matter. I thought that was a really excellent presentation, and to be honest with you, it was, as you said, comforting to sort of see that a lot of the factors cited aren't just unique to ourselves. So well done on that. I think there's a few distinguishing factors. One is the lack of specialties on site. So in Naas here, we have general medicine, we have general surgery, we have some specialties, but access to the likes of orthopedics and neurology is an impediment to good patient flow. And we often have to seek the input of consultants off-site, which can delay and slow things down. I'd also think that there potentially is less autonomy. Just the governance structures are quite different in many of the Model 4s and Model 3s, and maybe we have a little bit less autonomy in terms of developing pathways and developing the infrastructure at the speed and in the prioritization that we actually would like. And one thing that struck me there was the ICT. It's much richer, I think, in the Model 4s, and the sense of innovation and learning is very strong there. And it's probably much more mature than what we have here. And you could see, I think it was Silo and some of the initiatives being mentioned. That's something that we have tried to, I suppose, embark on, but it's proven quite difficult to date. And the other thing, Mike, that did strike me, that the clinical governance models here maybe aren't as evolved as they are in the Model 4s, that there's probably more established ways of doing business, more high-level input, perhaps subspecialty strategies and continuous monitoring of KPIs, and that's all pulled together in a collective sense. I think we're only in the infancy with regards to that, albeit that we recognise it's the way to go. So that was the main sort of differentiating factors I saw, but for the most part, an awful lot of overlap in terms of the issues identified.
Similar challenges on a day-to-day basis, Kieran, isn't it, really, from the point of view of the capacity piece? What we all share in common is actually running at 100% capacity, and how to change the system while we're running at 100% capacity. Peter, I might ask you just HSE South and West, obviously, which is a number of the 2 Model 3s, Model 4, and 2 Model 2s as a group, plus the community, which is the whole point of the RHA. And I know obviously Andy Phillips is looking at the high impact changes that might make a difference. I mean, have you landed on the areas of hurt that are worth going after? I mean, clearly cohorting is one from the point of view of utilising inpatient beds.
And Mike, maybe if I could make some comments on that, but also if it was possible to come back with 1 or 2 questions to the matter group, it would be great. Just specifically on cohorting, I was delighted to hear that you spent quite a bit of time. And again, can I compliment you on a fantastic presentation, beautifully clear, and really your presentation technique was great. With regard to cohorting, I mean, something that strikes me as forgotten is that it is remarkably disrespectful of our nursing colleagues that we don't demand cohorting as the norm. And the specialty skills that are built up by nurses in our specialty wards are invaluable and vital, I think, for a safe patient course. I'm curious, are you finding a solution towards effective cohorting apart from, Jim, you mentioned capacity is clearly the straightforward answer, but with what you have, how are you going towards that? How are you moving towards that?
Heather, do you want to take
Yeah,
that?
I
maybe?
don't mind speaking to that. So, yes, incredibly difficult when we're in the level of escalation we're in, where patients just go to the next bed. There are a few things that we're trying. One is doing patient swaps to improve cohorting at the times when we are quieter. So, for example, I think it's reasonable to set a minimum number of patient swaps to happen on weekends when the movements in and out of wards are slightly quieter. The other piece that works very well is to ask specialty wards to identify their next patient in. So while we may not be able to pull, they may not be the appropriate patient in the emergency department to go into their bed, wards and specialties will often have a outlying patient that they would like to bring in as their next patient in. So those are two fairly practical ways that we're aiming to do it. There's certain specialties that lend themselves. The GIM meetings, those GIM handover meetings are very helpful for us as well, because we get at a single point in the day after take an identification of patients into specific specialties. And for many, many reasons within patient flow and efficiencies in care planning, that single point of decision of specialty takeover is hugely helpful.
Excellent. Maybe just to comment, Mike, on one of the many areas of hurt. It is a sea of hurt, I'm afraid, managing UEC. Was a concentration on our over 75 breaches that we've spent a lot of time and energy in the last year on, and in fact with good effect. We went from, I think, some of the worst performance to some of the best on a fairly consistent basis. But I think you mentioned, Heather, the fact that how do we get things to stick? Because just today we have 5 breaches in our Model 3, in one of our Model 3s, and one in our Model 4. You know, it is as improved as the performance has been, it's still fragile, and the smallest thing can actually see it deteriorate. And I am reminded by colleagues across the organizations is that, you know, we do achieve in this area, but it has a cost in others. So surgeons would certainly, you talk, Jim, about the fact that you have a red line at cancelling elective work. We haven't had quite that red line, and less than critical work has been cancelled in the last year or more. And it is highly disruptive.
Yeah, thanks, Peter.
Yeah.
Okay, thank you. The clock is slightly against us, actually, but there's a couple of comments in the chat, actually. Austin Waters wondered about better community engagement, supporting complex patients. And in fairness, we'd all vote for that, Austin, isn't it? That integration piece, which is a part of the journey of the RHOs, REOs, one would hope would improve. And we did see maybe that relationship broken down in COVID because of, like, we don't want to get COVID from the acute hospital, vice versa. But that is improving. And there's a long journey. Brendan O'Reilly, who's Chief Operations Officer at CUH, just talking about the 75 target having a knock-on effect on cohorting then, because obviously there's a priority to get the over 75s into bed. So I think that's a balanced point. And in addition to that, Ishak El-Suni mentioned about balancing safety versus discharge. And I think in fairness that's always kind of cut to the fore. You know, you can push and push and push, and then obviously there can be adverse events. So I think that's probably about as much as we've time for. I'm just very conscious of people's time at this time of the year. Can I just thank Aileen, Heather, and Siobhan for really sharing, as Peter said, really crystal clear presentation about the challenges and how you've gone after it. And those are replicated up and down the country, really, from that point of view. And we're all in this together, which is the point of the Patient Flow Academy, that we share this. This will be recorded. Can I also thank Kieran from his busy schedule, and Peter and Jim as well also for joining, and mostly all of you who have attended. Thank you for following the webinar series. We'll continue into 2025, a topic suggested by yourselves. The point is building a collaboration and a community of people that know maybe the correct things to do. And most importantly, maybe I wish you a peaceful and happy time with your friends and family over Christmas. So thank you very much indeed.
Thanks, Mike.